Have you ever wondered how a single breakthrough study can transform the entire approach to managing a complex disease? Welcome back to ShockDoc Medical. I'm Dr. Raad, and today we're diving headfirst into the intricate world of Behçet disease. Buckle up, because in this episode, we're unpacking every detail of this rare, chronic, and multi-system condition that has puzzled clinicians for decades. Imagine sitting down with a friend over a hot cup of coffee, chatting about a disease that doesn't just affect one part of the body, but can challenge nearly every system. Behçet disease is exactly that, a condition characterized by relapsing inflammation that can manifest in many ways. Although its precise pathogenesis remains a mystery, we do know that it involves immune complex-mediated vasculitis. Interestingly, while it's most prevalent along the historic Silk Route, in places like Turkey, Iran, and Japan, it can show up anywhere in the world. And there's a strong genetic link too, especially with HLA-B51. Today's episode is a must-listen because we're not only exploring the clinical features and diagnostic criteria of Behçet disease, but we'll also break down the investigative tools and treatment strategies available to manage this multifaceted condition. So let's dive in. Let's start with the basics. Behçet disease is an enigma in many ways. It's rare, chronic, and its course is relapsing. It primarily involves immune-mediated inflammation of the blood vessels. Now, if you're wondering what you should look out for clinically, here's a rundown. Mucocutaneous manifestations. Oral ulceration. Every patient with Behçet disease experiences recurrent, painful oral ulcers. The small ones typically heal without leaving scars, but if they're larger, you might end up with some scarring. Genital ulceration. Seen in about 85% of patients, these ulcers often appear on the scrotum or labia, and in women, they may affect the vagina or cervix. They, too, can leave scars. Papulopustular lesions. Also affecting around 85% of patients, these lesions start as papules on an erythematous base and evolve into pustules over 24 to 48 hours. They often resemble acne or folliculitis and are commonly found on the trunk. Erythema nodosum, EN-like lesions. Present in about half of patients, these lesions typically appear on the legs and resolve with pigmentation. Superficial thrombophlebitis. About a quarter of patients develop tender erythematous subcutaneous nodules in a linear pattern, sometimes getting mistaken for EN. Extragenital ulceration and pathergy. While less common, ulcers can occur at other sites. Plus, the phenomenon of pathergy, where a simple needle prick leads to a pustule or papule after 24 to 48 hours, is a striking feature of Behçet disease. Ocular involvement. Around 50% of patients experience eye disease, particularly chronic, relapsing anterior and posterior uveitis. This is not just an inconvenience. It can lead to retinal hemorrhage, papilloedema, macular involvement, and ultimately a loss of visual acuity, posing a real threat of blindness. Musculoskeletal, neurological, and vascular involvement. Musculoskeletal. Roughly half the patients have non-deforming, non-erosive peripheral oligoarthritis that usually lasts a few weeks. In some cases, it can progress to chronic arthritis, osteonecrosis, or even myositis. Neurological. Though only about 5% of patients are affected, neurological involvement can be severe, with pyramidal and cerebellar signs, sensory deficits, sphincter disturbances, behavioral changes, and even dural sinus thrombosis. Vascular. Also around 5%, large vessel vasculitis can lead to thrombosis and vascular occlusion, which is a serious concern. Other systems. Occasionally, you may encounter gastrointestinal mucosal ulceration, splenomegaly, glomerulonephritis, or even cardiac involvement. So how do we put the pieces together? The diagnosis of Behçet disease is primarily clinical. Here's what we look for. Pathergy test. This is a hallmark test where a skin prick on the forearm induces a papule or pustule within 24 to 48 hours. While the sensitivity of this test varies, being highest in Japan and Mediterranean countries, it's highly specific for Behçet disease. Biopsy. We often biopsy papulopustular lesions or any positive pathergy reaction to gain further insights. Exclusion of infections. For patients with genital ulcers, it's critical to rule out infections like herpes virus or EBV. Laboratory tests. A full blood count FBC might reveal an anemia of chronic disease and leukocytosis, but keep in mind that inflammatory markers aren't always reliable indicators of disease activity. Autoimmune markers such as ANA, rheumatoid factor, RF, and anti-neutrophil cytoplasmic antibodies, ANCA, are typically negative. There are a couple of criteria we often use. The International Criteria for Behçet Disease, CBD, employs a point scoring system. Ocular lesions, 2 points. Genital aphthous, 2 points. Oral aphthous, 2 points. Skin lesions, 1 point. Neurological manifestations, 1 point. Vascular manifestations, 1 point. Positive pathogy test, optional, 1 point. A total score of 4 or more indicates a Behçet's diagnosis. Similarly, the International Study Group ISG criteria emphasize recurrent oral ulceration with at least 3 episodes in a 12-month period, plus any 2 of the following: recurrent genital ulceration, eye lesions, skin lesions, or gastrointestinal lesions. Now, let's talk treatment, and believe me, there's a wide range of options tailored to the disease's many facets. I promise, if we mention a treatment, we're going to get into the details, including the medication and doses. Topical treatments for oral and genital ulcers. Clobetasol propionate, a very potent topical corticosteroid ointment, can be applied along with a 2% lidocaine gel to relieve pain. Oral ulcer care. Caustic solutions, such as silver nitrate 1 to 2%, tincture amura 5 to 10% weight volume, hydrogen peroxide 0.5%, and methyl violet 0.5% can be used 1 to 2 times a day. Antiseptics and anti-inflammatories. Options include Amlexinox 5% oral paste, triclosan 0.1% mouthwash, and various specialized toothpastes that incorporate amyloglucosidase or glucose oxidase. Corticosteroids for oral ulcers. Triamcinolone mucosal ointment, dexamethasone mucosal paste, or betamethasone pastilles applied 4 times daily or at night are common. For targeted relief, intrafocal infiltrations with triamcinolone suspension, 0.1.5 milliliters per lesion, can be administered. Anesthetics, lidocaine, 2 to 5%, mepivacaine, 1.5%, or tetracaine, 0.5 to 1% gels are used 2-3 times daily, though caution is needed for those with allergies. Additional options: 5-aminosalicylic acid, 5% cream, 3 times daily, cyclosporin A 500 milligrams solution for mouthwash 3 times daily, and sucralfate suspension, 5 milliliters, 4 times daily, can also be beneficial. Dietary measures. Adopting a mild diet and avoiding hard, spicy, or salty foods, and even certain mouthwashes and toothpastes can reduce irritation. For cutaneous and genital lesions, topical corticosteroids, TCS, potent or superpotent TCS, applied once daily or twice daily, are essential. Colchicine, often used in conjunction with TCS. Start at 500 micrograms once daily, increasing to twice daily after 1 week, as tolerated, up to a maximum of 2 milligrams. Topical calcineurin inhibitors, such as pimecrolimus, have shown promise in reducing healing time in genital ulcers. Other agents, in cases of severe disease, azathioprine or biological agents might be indicated. Dapsone has also been studied and shown benefit in reducing genital ulcers. Systemic treatments. For patients with Adamantiades Behçet Disease, systemic treatment is tailored to the severity and organs involved. Colchicine, dose 1 to 2 milligrams per day orally. Used for oral aphthous, genital ulcers, folliculitis, and erythema nodosum. Note, in females, a dose of 1.5 milligrams per day may be tried, although efficacy may vary. Apremilast, dose 30 milligrams twice daily PO for up to 16 months. Used for improvement and prevention of oral aphthous, though mild gastrointestinal symptoms can occur. Ribamepide, dose 300 milligrams per day PO. Used for oral aphthous with a caveat for pregnancy and lactation. Methylprednisolone. Options: 40 milligrams IM every 3 weeks for erythema nodosum, or 1,000 milligrams per day IV for 3 days, in combination with cyclophosphamide, azathioprine, and prednisolone IV for 6 months for posterior uveitis retinal vasculitis. Dapsone, dose 100 milligrams day PO. Note: monitor for methemoglobin levels. Supplement with ascorbic acid 500 milligrams per day if needed. Used for oral aphthous, genital ulcers, skin lesions, and a positive pathogy test. Interferon A2A, dose 6 times 10 IU subcutaneously, 3 times per week. Used for oral and genital ulcers and papulopustular lesions. Caveats: not recommended in pregnancy or lactation due to potential psychotic signs and myopathy. Thalidomide, dose typically 100 milligrams per day or 300 milligrams per day, though minimizing to as low as 25 milligrams per day may help mitigate the risk of polyneuropathy. Used for oral aphthous, genital ulcers, and papulopustular lesions. Caution: contraindicated in pregnancy and lactation. Anti-TNF biologic agents: etanercept 25 milligrams twice weekly PO. Infliximab 5 milligrams kilogram IV on days 1, 7, 14, and 28, or alternate regimens as appropriate. adalimumab, 160 milligrams SC on day 0, 80 milligrams on day 14, then 40 milligrams or 80 milligrams based on clinical response on day 28 and every 2 weeks thereafter. Used for severe cases including refractory ocular lesions, neurologic involvement, and vascular manifestations. Azathioprine, dose 2.5 milligrams per kg per day PO. Used for recent onset ocular disease. Caution, avoid in pregnancy, lactation, severe liver disease, or bone marrow depression. Cyclosporin A, options, up to 10 milligrams per kg per day PO in some cases, or 5 milligrams per kg per day for visual acuity improvement. Used for ocular manifestations, oral ulcers, skin, and genital lesions. Caution, contraindicated in CNS involvement and use with caution in lactation and renal insufficiency. Other systemic agents, azapropazone, 900 milligrams per day PO over 3 weeks for arthritis. Acyclovir, although attempted, 5 × 800 milligrams for 1 week plus 2 to 400 milligrams per day for 11 weeks, it has been found ineffective. Interferon alpha at other dosing regimens, secukinumab and givokinumab. These have also been studied, with some regimens proving ineffective for certain manifestations. Anticoagulants. Meta-analysis indicates that while they're ineffective against thrombosis in this context, not using them might increase the risk of post-thrombotic syndrome. Additional systemic options for Adamantiades Behçet Disease. Pentoxifylline, 300 milligrams 1-3 times day PO, especially in children for recurrent oral aphthous. Oxbenifylline, 400 milligrams 3 times day PO. Soglidine, 2 to 4 milligrams day PO. Indomethacin, 100 milligrams per day PO for mucocutaneous lesions and arthritis. For ocular lesions, long-term visual prognosis, arthritis, and vascular lesions, interferon A regimens. For example, 9 × 10C IU 3 times per week or 3 to 9 × 10C IU 5 times per week with maintenance dosing based on body weight have been explored. Corticosteroids administered either orally, 5 to 60 milligrams per day, prednisolone equivalent, or IV in acute exacerbations, 100 to 1,000 milligrams per day over 1 to 3 days, remain an option despite potential side effects such as diabetes or psychosis. Other agents for refractory or severe manifestations include tacrolimus, 0.5.2 milligrams per kg per day, PO for refractory uveitis. Cyclophosphamide, 1 gram month IV bolus with Mesna 200 milligrams to reduce hemorrhagic cystitis risk for neurologic involvement. Chlorambucil, 0.1 milligrams per day PO, maintenance dose up to 2 milligrams per day for neurologic manifestations, uveitis, thrombosis, and mucocutaneous lesions. Methotrexate, 7.5 to 20 milligrams once weekly PO for severe mucocutaneous lesions, arthritis, or progressive psychosis dementia. Sulfasalazine, 1.53 grams per day PO for gastrointestinal ulcers. Thalidomide, adjusted dosing, ranging from 1 to 3 milligrams per kilograms per day for intestinal involvement, particularly in children, while monitoring for neurotoxicity. Prevention is as crucial as treatment. Patients with severe or progressive recurrent aphthous stomatitis should be followed closely. They're potential candidates for developing full-blown Adamantiades Behçet disease, especially if there's a familial trend. Early referral to specialists and a multidisciplinary team is essential. In fact, the diagnosis and management of Behçet's disease should involve a range of experts, from ophthalmologists to rheumatologists and dermatologists. Male patients with systemic involvement or early onset are at a particularly high risk for poor outcomes, so systemic treatment may be warranted sooner rather than later. I find it fascinating how Behçet disease challenges us to think beyond a single organ system. It's like an intricate puzzle where each piece, from oral and genital ulcers to ocular and neurological signs, contributes to the full picture. I often ask my colleagues, what if our understanding of these diverse manifestations could lead us to a unified, targeted therapy? And with the advent of biologics and newer immunosuppressants, we're inching closer to personalized treatment strategies that not only manage symptoms, but also potentially alter the disease course. Have you ever experienced a moment where a treatment's specific dose, say starting colchicine at 500 micrograms once daily and titrating up to 2 milligrams, made all the difference in patient care? These nuanced dosing strategies remind us that medicine is as much an art as it is a science. As we wrap up today's deep dive into Behçet disease, let's recap the key points. Behçet disease is a rare, relapsing, multisystem condition with hallmark mucocutaneous lesions, ocular involvement, and potential systemic complications. Diagnosis relies on a combination of clinical criteria, whether through the ICBD point system or the ISG criteria, and careful exclusion of mimicking conditions. Treatment ranges from potent topical corticosteroids like clobetasol propionate and lidocaine gel and colchicine, to a suite of systemic therapies including immunosuppressants and anti-TNF agents with precise dosing tailored to the manifestation and severity. I encourage you to join the conversation. Like, subscribe, and share your thoughts or questions about today's episode in the comments. How do you think emerging biologics will shape the future of managing complex diseases like Behçet's? And what challenges have you encountered in your practice or studies? Stay tuned, because next week on ShockDoc Medical, we're set to uncover another groundbreaking discovery that could very well change everything in the realm of medical innovation. Thank you for joining me, Dr. Raad, on this journey into the depths of Behçet disease. Until next time, stay curious, stay informed, and keep pushing the boundaries of medical knowledge.